Gentlemen, and now move on to the gentleman from Maryland, probably the one real expert we have on this committee that knows something about what he's talking about. So,
thank you,
Dr.
Mr. Chairman,
Harris.
I think. Thank you, Madam Secretary, for coming before the committee, and welcome. First, a couple of questions that are just very short because my time is limited. With reference to the Independent Payment Advisory Board, or IPAB, you know, the budget document says that this is one of the mechanisms that is going to reduce long-term drivers of Medicare costs. Do you intend to appoint members to that board this year?
If the Congress makes recommendations, we would welcome those.
You don't need congressional recommendations. Do you intend to? The law, the ACA, very specifically says you have the authority to appoint the board. Do you intend to appoint the board?
It says in consultation with the Congress, and that's the part we would like to have.
Just to follow up to Mr. Simpson's question on ICD-10, since the CMS website says that you can run ICD-9 and ICD-10 parallel, pretty clearly says it can be done, would you consider creating a hardship exemption for ICD-10 for physicians whose practices just can't afford to convert to ICD-10?
Would want to understand how that would actually work in terms of those physicians, if that's something that, you know, happy to understand and take a look at that question. I think we believe everyone should switch and that people are ready.
I fully understand how the government thinks everybody should switch to the regulatory scheme proposed by the government. I am telling you this is one of the largest concerns of small physician groups, the ones we want to help, the small rural physicians who can't afford to convert to ICD-10. The CMS website clearly says they can be parallel. I would hope you'd be opening to creating a hardship exemption. Maryland's health exchange was a disaster. They're now in court. They're going to try to recover money from contractors. I just want to ask you, Madam Secretary, if Maryland recovers money from contractors, are you going to seek the return of that money to HHS?
With regard to the issue of how these contracts were done, it is a matter of when the contracts that we had with the states, in terms of the agreements we had with the states, depending on why the money comes back and what was done wrong, is the answer to that. Where we have the ability to, in terms of our relationship, sometimes those actually have to do with the contract with the state, not with their relationship in terms of fulfilling their commitments to the federal government. Where there are cases where that can happen, that's something we'd like to understand.
Thanks.
And our IG is working on
The
that.
overall budget increase proposed was an increase of 6% to HHS. That's right, round numbers.
Yes.
Why is NIH only 3%? I mean, if the administration always talks about the importance of research and all, why actually would you disproportionately not raise the primary driver of basic medical research in the country? I mean, why would you choose to expand other parts of HHS and not to expand NIH at the same extent?
So with regard to the increases across the department, we believe that a $1 billion increase for NIH is a healthy increase. And NIH, in terms of what it's seen over the period of time, has been different in different areas. Some of the increases that are larger, we just actually spoke about one of the ones with your colleague in terms of some of our program integrity efforts have larger increases in percentage terms than, say, NIH does. Another area is we're working very hard to implement the Congress, the legislation that you all gave us with regard to FSMA and food health safety, and so there are increases that are larger in other parts of the department.
So a decision was made to not prioritize NIH for their share of the 6% increase. I mean, again, it's the numbers are the numbers. The administration says we need 6% more for HHS, but you only need 3% more for NIH.
With regard to how we put a budget together, I think area by area and operating division by operating division, we determine the needs, and then we have to make choices and trade-offs in terms of how we do that. In terms of taking a percentage and giving everybody a percentage increase, that's actually not how we put our budget together. What we did was work through, as I said, whether it's particular needs that we have in program integrity or the implementation of laws that we have, there are places where we need larger increases.
I fully understand the prioritization. I'm a little disappointed that the administration, and let's face it, this is kind of a make-believe budget because it doesn't accept the budget caps that are in current law. So at least in your make-believe budget, I would have hoped that you would give the NIH the average increase in HHS. With regards to the Strategic National Stockpile, can you assure the committee that your fiscal FY16 budget request for the SNS will be sufficient for procurement of both newer medical countermeasures and for the replenishment of the existing stockpiled medical countermeasures?
We have proposed the budget that we believe will meet those needs, as well as what we believe we can adequately spend in terms of making sure we're managing the taxpayers' money well.
And will that be enough to procure the 75 million doses of anthrax vaccine that would be needed?
With regard to the specific of that particular procurement, that's something I want to get back to you on.
I'd appreciate that. Thank you, Mr. Chairman. I yield back.
Hey, Mr. Harris, you'll have the last questions.
I guess I sit between us and lunch. Just very quickly, as you know, the ORR grants provides grants to institutions that provide housing for the UACs. And, I was very disappointed by the Christmas Eve regulation that basically set regulations on some of these faith-based. 6 of the 9 grantees are faith-based. And they do feel that their religious freedom is going to be impinged by these regulations. And, you find yourself with a department that's really the tip of the spear, and what many people, myself included, feel is a war on religious freedom in this country. I would hope that you take their comments, the comment period ended Monday, into account for the final regulation. When your predecessor was here last year, I asked her about the non-transparency of abortion coverage in exchanges. And the department comes out with their definition of separate payments that is just mind-boggling because it's not a separate payment, which would add to transparency. So I would hope that you would take some steps to modify the rule that make it really a separate payment, which provides some transparency. And just finally, a question for you. What's come to my attention is that a lot of the plans on the exchanges are putting all the drugs for a given disease in their top tier. So what you're doing is you're basically giving people a plan that covers a routine physical, but God forbid they get a disease where they require an expensive medication. Tiering is actually doing 2 things. One, it actually discourages them from taking plans, so it actually it puts high-risk people in. It doesn't allow them access to really all the plans. And the other one is, strangely enough, tiering is actually supposed to discourage people from taking the top-tier drugs because a lower-tier drug would do the same thing. But what we're finding is that all the drugs for a disease are being put in the top tier. Is this adverse tiering something that the department is going to do something about in these plans?
With regard to the issue, as these issues have come in and been raised, they've been raised in some specific actually disease areas, HIV and some others. We are continuing to look at them on a case-by-case basis and overall. And so when these have come in, we are having the conversations and understanding and working with the states and the insurers to talk about these issues. As these things come in, we want to work on and figure out how we can create a situation where people do have the access, which I think is your point, to the quality care they need.
Thank you
we
very
agree
much.
with that.
I yield back.